All right, hello everyone. I'm Jeffrey Young. I'm a periodontist. I've been asked today to kind of give my perspective as a periodontist on the current state of implantology, where we are just in implant dentistry in general, plus my perspective on MagiCore implants. So here we go. So you guys all know who this man is, right? If you don't, you either don't place implants or you're a spy or some, I don't know, hidden somewhere in a small part of this world. I think if we've done any implants or restored any implants, this man right behind me is someone we should all know, Dr. P.I. Brandenmark. Basically, his discovery obviously is what led us to where we are today. In the years following Dr. Brandenmark, we all know there's been numerous researchers, clinicians, biomedical companies, all partaking in this evolution of implants. So when I was asked to talk about my perspective and give my perspective on the current state of implantology, I figured it was best to at least kind of go back in history. Obviously, I wasn't there at the time. I'm not old enough to be there. But maybe some of you guys have, I don't know. But as we know, following the osseointegration discovery, there's been a lot of research and advance in technology in the augmentation area of implantology. But it seems like even now, about 50 some years later, here we are still talking about augmentation techniques involving hard tissue and soft tissue. Part of that reason, obviously, is because of how we transitioned from going from bone-centered placement to prosthetic-driven implantology or implant placement. And therefore, instead of matching the placement to the patient's bone anatomy, now we are trying to match the patient to the prosthetic-centered placement, therefore needing augmentation procedures. So a lot of studies and a lot of techniques and protocols have been developed ever since, as you all know. But like I was saying, even here we are some 50, 60 years later from the day of Dr. Brandenmark, and here we are still talking about new techniques, new biomaterials, new bone graft materials, new membranes, and even just 3 weeks from now is our Perio Association's annual convention that's going on, and I looked over, the hot topics, that's being discussed, and still it's about augmentation procedures and materials of choice, and on top of that, which I'll get into, is about periimplantitis. So it seems like on the surface we've come far. We've, with all the advance in technology, we've come pretty far, but I have a feeling like we are kind of in a standstill, and we're still talking about the same things over and over again, and not really hitting the core of the main issue that's presenting to us. So where has all of this research and study and invention of technology and biomaterials, where has it led us? Where are we today? What are we seeing with our implants? And if you haven't done any implants, or at least placed them yourself, at least you've restored them, right? Or at least you've seen patients come into your practice with situations like this. And as a periodontist, and the fact that more and more clinicians are placing implants, more and more of these patients are coming my way to a periodontist, where we're looking at early bone loss or late bone loss or whatever it is. We're seeing on x-rays and clinically, we're seeing a lot of inflammation. And on radiograph, we're seeing all these, whether you want to call it bone remodeling or actual bone loss. I mean, there's some joke in the dental community. If I place it, it's bone remodeling. And if you place it, it's bone loss. But whatever you want to call that, we are, the truth is, the reality is, we are seeing some of these cases come back or come to our door, and we're seeing all these losses of the hard tissue. And what bothered me is the fact that you do everything by protocol per manufacturer. And as a periodontist, I place multiple brands of implants. And you follow their protocols, and you're doing everything the right way. But some cases don't turn out the way you imagined. And you start scratching your head, like, what did I do wrong, or what's wrong with the patient? What's going on? You just stare at the x-ray and you don't know. And well, now I know because of what IBS and MagiCore has developed, and comparing that to our bone level systems that we're so used to, and just comparing that alone, I'm learning a lot more about the biology and the importance of soft tissue, even more than my training, 10 plus years ago at, the perio residency that I went to. And we can sit here and go over, what are the causes of this? What are the causes of bone loss? I think one of the biggest challenges for us speakers was trying to compact this in 20, 30 minutes. So I don't have time to go over all the causes, but here's a list. Simply, we can group them into local, systemic, and social factors. Okay? Local meaning, the implant itself. Systemic, looking at the patient. And social, obviously looking at their background as well. We can also group things into stage of bone loss, when it's occurring. Is it early bone loss, meaning right after it's been restored within a year, or late bone loss, meaning starting to see it after that 1-year mark, okay? And as you can see, there's a lot of reasons. Surgical trauma, establishment of biological width, presence of a microgap, peri-implantitis, occlusal overload, implant crest module issues, and late bone loss. Same thing, overloads, parafunction, peri-implantitis, you name it. Now, if you haven't caught it already, some of these are kind of grouped into a bundle because of bone level implants, okay? Presence of a microgap, the inability to establish a sound biological width, surgical trauma, because a lot of times we need to lay a big flap and perform some augmentation procedures. Implant crest module, in a bone level implant, having a 2-piece system and having those micro movements, like all those things are kind of grouped, in my mind, into a single category called bone level implants. Now, you're not going to hear that a lot in other conferences or literature. They're not just going to come out and say bone level is the issue. Because the reality is 90% of the implants we do are all bone level. And major companies are big on these bone level implants. They've invested a lot in bone level. So you're not going to hear it come out that way. In fact, I might get some heat from my colleagues for saying that. However, I'll take the heat. Now, what has that led us to, the current state of implantology? It has led us to look at, we're almost forced to look at treatment options on managing periodontal disease, or in this case, perimucositis or peri-implantitis. And as you can see on this slide, there's a lot of different ways. And it was kind of a good segue from our last speaker on showing his cases on periodontitis or peri-implantitis. Some of the methods that were recommended, such as implantoplasty, turning something rough into a smoother surface, But as you can see here, there's a lot of different methods for a reason, because there is no perfect way to manage it, okay? In fact, a lot of times it's a combination of a lot of mechanical methods, some chemical, use of laser, and we do that during the surgical method, whether it's regenerative or resective. So it's a combination. It's like a cocktail of whatever works in our hands and what we think is going to help. Okay, but the reality is, once we get our implants into this state, it's almost impossible to get it back to what it used to be. And I know there are procedures out there like LaPip using Nd:YAG lasers to regenerate tissue, regenerate bone. However, I think eventually the same problem is going to present itself again if we don't handle the core issue, okay? So to me, as a periodontist, it's almost like we went from trying to treat disease to save teeth to now trying to save implants. You know, from the cases that are coming my way, we're taking teeth out because it's periodontally, you know, hopeless, and putting implants in, but we're seeing the same things happen to our implants we put in a few years later. And now we're trying to save those implants. So it's a vicious cycle. So in my mind, what I want to talk about today is, why don't we stop for a moment and be proactive about it and think about how to prevent this from happening versus being reactive and thinking treatment options or treatment modalities. Okay. And to me, in my opinion, these two factors are the most important factors in both preventing early bone loss and late bone loss. Okay. Throughout the entire day today, you've heard or seen a lot of cases being presented, especially from Korea, where they're doing immediate placements and talking about soft tissue housing concept. And I was sitting there with you guys, listening and looking at the questions being presented, and I'm super excited to see these questions because that tells me you guys are getting it. You guys are understanding what they're doing. You're understanding the importance of this soft tissue housing and what's been missing in the bone level implant dentistry. So mucosal seal is basically what soft tissue housing concept is. It's the establishment, it's the early establishment and a definitive establishment of the biological width. Okay, and that can only be done because of the magic cuff that you see in our MagiCore implants. And on top of that, the shallow sulcus depth that's formed once it's restored. And that's because of the junctional epithelium and where it's attached, up high at the cuff. And eventually, after being restored, you get the physiologic formation of a sulcus, which we are calling that on-growth. And I know we have a speaker talking about that tomorrow, so I'm excited to hear that. Thread geometry, we've heard that today as well, thin threads, and the game-changing engineering behind that, you know, and how it distributes the forces to the bone in harmony because of the engineering behind that. And to me, thread geometry, it's important for at placement and during the initial healing, but in addition to that, to me, it's really important for the future of that implant. Because I'm sure you guys have seen cases where the crestal bone may look pretty good, but you see in the thread area, you see some radiolucency happening. I don't know if you guys have seen that. But to me, that's because of this right here, the thread geometry on bone level implants. and the difference with the fin threads on the MagiCore. The fin threads in the MagiCore, it has the ability to prevent these microfractures that occur from the occlusal overload that may be happening on these implants. And by the stress distribution and the functional surface, how it's different than bone level implants, it allows for all this to distribute harmoniously around the threads, around the bone. Okay, so to me, these two things, mucosal seal, only available with these magic cuffs, and thread geometry with the fin threads. These 2 points, I mean, there's a lot more, obviously. However, if I were to decide on 2 main things, these 2 things are both important for both preventing early bone loss and late bone loss. And going back to that soft tissue housing concept, and I know they've done well explaining that, but I want to go back to the perio side of that. And this is something we've known about since the 60s in classic periodontal literature by Dr. Pritchard, where he did a case report and study on the etiology, the diagnosis, and treatment of intrabony defects. Okay, so these are your typical period defects around a molar site where you have 2-3 wall defect. And back in the 60s, before we had numerous choice of bone graft and membrane materials, we were still having results like this. Okay? In this particular case, Dr. Pritchard here is showing a case where no bone grafts were used, and the only thing that was done is mechanical debridement on the root, so your routine root planing procedure, some saline to irrigate that defect area, and basically closed the soft tissue. So we're talking about closing the door in that soft tissue area, allowing an opportunity and environment for bone to grow. Okay, so you saw earlier today those immediate cases that the doctors from Korea were presenting. They placed the implant. They had nice soft tissue seal around the cuff, and eventually what do we see? A lot of them didn't even do bone grafts. We're seeing what we are seeing from the 60s. Okay, so soft tissue housing, super important. How important is it? Well, we know, well, we were on board with that early on, but we now have other companies getting on board with it, okay? I'm sure you guys know this. It's Noble Biocare. They're calling it the muco integration era. That's their coined term, but we've been calling that soft tissue seal, soft tissue integration. You know, but these big companies, they like to, you know, coin things. So here we are. Now we hear muco integration era. And they've developed certain things to their existing implants, such as anodizing their surface for better tissue attachment, things like that. On one concept where they're trying to mimic that, you know, the cuff part, basically, of MagiCore. But the good thing with this is that a lot of it is marketing, but the good thing is that the fact that they're identifying the main issue, that they are not trying to hide it, but they are actually seeing and presenting the importance of that soft tissue attachment. So to me, it's a positive thing, you know, that other companies, major companies, are starting to get on board with it. However, the reality is it's still on a bone level implant, and it's still a two-piece system, so you're still going to have micro gaps and micro movements. So to me, even if you get crestal bone stability, I don't know if that's going to be a long-term solution. Okay. So what is the real solution, in my opinion, and a lot of others' opinion, is what we're seeing right now and talking about right now is MagiCore. Okay. And as a periodontist, just wanted to point out, obviously there's many advantages with this implant, but talking about junctional epithelium adhesion I talked about earlier, forming that shallow sulcus depth, and the connective tissue adhesion, creating that mucosal seal early on, and maintaining it throughout the restoration and never being disrupted. To me, on top of everything else everyone else has mentioned, as a periodontist, those two things are a game changer. And I know you've heard everything I've said, and it's nothing new, right? Past symposiums and now. Dr. Wong has mentioned it, has taught us that. And I'm pretty much saying the same thing, and it's because that is the game changer. And I can't emphasize the ingenuity and the importance of his design that allows us to accomplish what we strive for, all of us. There's a lot more I want to talk about, but I believe my time is up. So thank you for paying attention, and I'll take some questions.